Today we will have andrology, stones, and endourology, upper tract endourology. So I'm the first one to speak, and then we will have in the screen in a moment my colleague Sax Minhas that will participate also. I like to have some interaction with you, and you are welcome to ask questions and to participate as much as possible. So my part, the andrology part, will be from 8:30 to the lunch time, will be 12:45, sorry. I will speak the first 2 hours. I will speak about the erection, erectile dysfunction first, and then I will make a presentation on penile curvature and then priapism. Okay, so this will be my talk, and then my colleague, we will have the coffee break, and then my colleague Sax Minhas will speak about infertility, the surgery for infertility and vasectomy, and some hypogonadism. So that will be the andrology part, and then Professor Scofone and Skolarikos will talk about the stones and the upper tract endourology, and he will explain what will be the distribution of that. So let's start with the first part, erection, erectile dysfunction. Okay. Okay, so this is the penis. What the penis is doing in erection is just trapping blood in pressure. So it's taking pressure from the blood, and becomes first engorged, big, and then hard. Okay, so that is what the penis is doing during erection. How is this controlled? What is the mechanism of control of this? Well, it depends on the tissue in the corpus cavernosum. There are two main things. One is the cavernosal tissue, which is like a sponge. You see, it's like a sponge with the trabecula, with the walls of the sponge that are composed mainly, I mean, it's a connective tissue, of course, but it's mainly smooth muscle. Okay, and there's also arteries that are controlling the pressure, are also in the walls of these arteries, the small ones, not the cavernosal artery, but the Elicine arteries, that are the small arteries that have also a smooth muscle in the wall. Okay, so is the tone of this smooth muscle, the one that is in the arteries and the one that is in the trabecula, they're responsible for erection, and it's very simple. Very, very simple. If you have the smooth muscle, what is this? It's not working. This is not working. I'm sorry. Oh, no, okay. Okay, so it's the tone of the smooth muscle that is controlling the erection. It's the main determinant of penile erection. That is probably the most important thing you need to learn in erectile dysfunction. If the smooth muscle is in contraction, the penis is in flaccidity. Contraction, flaccidity. If it's in relaxation, you have an erection, okay? Everything you can do to produce or to enhance the relaxation of the smooth muscle, it will increase the erection, okay? If you are putting something that relaxes the smooth muscle in the penis, will produce an erection. And if you inject something in the penis that produces contraction, it will produce a flaccidity, okay? We use that for the treatment of erectile dysfunction. And the discovery of Viagra, sildenafil, is based on this fact, okay? This is probably, again, the most important thing you need to learn about the management of erectile dysfunction, and to understand the mechanism of erection, and to understand why erection is damaged by several risk factors, okay? So remember this, very important. How is controlled the smooth muscle tone? It's controlled by the neural system, the autonomous system, nervous system, and is controlled by the cholinergic, the parasympathetic, and the sympathetic neural systems. So you have normally a tone that is adrenergic tone. There is you see here, alpha-1 receptors in the wall of the smooth muscle that is contracting that. So you have noradrenaline, and there's a tone of a noradrenaline all the time in the smooth muscle producing contraction. So in a normal situation, like now, you have this tone and the penis is in flaccidity. Every time the no adrenergic, no cholinergic neural system is releasing neurotransmitters like nitric oxide, then the penis will go in erection because they will produce a relaxation of the smooth muscle and produce relaxation. This is the first thing when you have a sexual stimulation, the relaxation of the nitric oxide in the penis, but also that has a very important role, the endothelium. You know that the endothelium covering or lining up the lacunar spaces in the penis and the inner wall of the arteries has a role in controlling the smooth muscle. It's a paracrine control of the tone, okay? If you have a stream of blood hitting in the walls of the endothelium, it releases nitric oxide, okay? Nitric oxide, this is the endothelium-derived relaxation of the smooth muscle, okay? So you need to have a good neural system releasing nitric oxide, and you need to have a good endothelium participating in this relaxation of the smooth muscles. But again, it's the relaxation of the smooth muscle that it produces the erection and is controlled by the neural system. It's an autonomous system, so you cannot control that. You cannot have an erection if you like. You just need to have sexual stimulation or maybe be in a deep sleep, okay? When you sleep, men, when we sleep, we have erections that are automatic. We don't control that, okay? So that is very important for you to understand. What is doing the nitric oxide inside the cell? You know, the nitric oxide that is released by the nerves by the endothelium. It goes into the cell. It doesn't act through receptors in the cell wall, and stimulates this enzyme, guanylate cyclase, and produces a change from GTP to cyclic GMP, okay? There is cyclic GMP that produces, at the end of a cascade of things inside the cell, the decrease of intracellular calcium, okay? If you have a decrease in the intracellular calcium, the muscle cell relaxes. It's attached and it relaxes and produce, you know, the beginning of the erection, okay? This mechanism is every time you have sexual stimulation, you release nitric oxide. It goes from the nerve at the beginning, then from the endothelium, go into the cell and produces relaxation. But this cyclic GMP is inactivated by the PDE5 inhibitors. Excuse me. It's inactivated by this enzyme PDE5, phosphodiesterase 5. There are 5. This is number 5 because there are 11 families of phosphodiesterase in the whole body, and particularly this one is in the penis. So if you are able to block this enzyme, the phosphodiesterase 5, then you will enhance the accumulation of cyclic GMP, and you will enhance the relaxation of the smooth muscle, and you will have more erection, more long-lasting, and harder erection, okay? So that is the base of the PDE5 inhibitors, again, sildenafil, vardenafil, tadalafil, or whatever the PDE5 inhibitors. Okay, so understand that because, again, it's very important. If you have questions, you can go in the microphone. There are microphones here, and you can ask questions if there's anything you want to ask. Okay, so this is this part that I think is very important to understand. It's very simple. Again, relaxation of the smooth muscle is the determinant of the erection, and then you can manipulate that tone. You can manipulate in the sense of enhance the erection or to contract. Why we want to contract? the penile smooth muscle. When? For example, if you have a priapism, you have an erection that is not going up, going off. You have an erection that is a priapism without any sexual stimulation. If you inject, let's say, adrenaline or phenylephrine, that is an alpha agonist, then you will produce the flaccidity of this patient, okay? So that is, again, useful to understand. Okay, how frequent is this? This is the MMAES, Massachusetts Male Agent Study. This was done many years ago. That was published in Journal of Urology many years ago in 1994. It is saying that 52% of men between 40 and 70 years of age have some degree of erectile dysfunction, okay? There's more than half of these people between 40 and 70 that are not happy with the erection, okay? They have some difficulties with the erection. Of course, the majority of them will be minimal erectile dysfunction or moderate, but still there are many patients or many persons, subjects with erectile dysfunction in every country. Probably in some countries are less than in others, but we did a study in Spain that many years ago also, and it shows that in a broader range of age, 25 to 75, it was like 20%. Okay, so 1 out of 5 men between 25 and 75 have erectile dysfunction, which is a number. I mean, there's a number of men with this problem. Okay, so it's something you will see many times in your offices, in your consultation, everyday urology practice, okay? Men with erectile dysfunction. What is the number one risk factors for having erectile dysfunction? Any guess? Number one, age, good. Age is number one. It's just age is an independent factor for erectile dysfunction, okay? If you are 25 and you have 1 chances of having erectile dysfunction, when you are 70, you have 24 times more chances of having erectile dysfunction just for your age. I'm 62 right now, so I have 14 times more chances of having erectile dysfunction than when I was 25, okay? Just for my age. Of course, age is something you cannot, control, or, you cannot take off these risk factors. There are some others that you can control and you can improve. For example, all the cardiovascular risk factors, because the cardiovascular risk factors affecting the endothelium. That is, again, as I said before, very important to control the tone of the smooth muscle. If you have a endothelial dysfunction, then you will have an erection problem, okay? What is producing endothelial dysfunction? All the vascular risk factors, smoking, hyperlipidemia, hypertension, diabetes, all that factors are producing endothelial dysfunction. There are 2 mechanisms why this endothelial or these risk factors can produce erectile dysfunction. First are functional changes. Functional changes meaning that you may have erectile dysfunction and endothelial dysfunction, but they respond to the treatment. They can go back if you control these cardiovascular risk factors, okay? So, for example, you will respond to PD-5 inhibitors because there's no structural changes, okay? What is at the beginning? Do you have a relaxation of, an impaired relaxation of endothelial, endothelial-dependent relaxation of the smooth muscle, so the arteries are not so much dilated, and the trabecula of that cavernosal tissue is not expanded, so there's a lack of arterial insufficiency, and then there is a veno-occlusive dysfunction. The blood is not trapping inside the penis. When there are some time after that, there are structural changes, and there's atherosclerosis. When you have atherosclerosis and the arteries are stiff and don't have the ability to dilate anymore, then you will have of course, a problem with the inflow of blood inside the penis, and an increase of the outflow because the smooth muscle is damaged, and there's an atrophy of the smooth muscle, and there's fibrosis inside the corpus cavernosum. There's no way that you can revert that with medication, okay? That will be the case of a patient that will need other treatments like a penile implant, a penile prosthesis, okay? So there's still treatments for these patients, but there's no functional response to that because the damage is irreversible, okay? So this is a table that we see that the risk factors for coronary artery disease and erectile dysfunction are sharing the same risk factors. Age, dyslipidemia, hypertension, diabetes, smoking, all that, okay? They are the same thing in coronary artery disease and erectile dysfunction. So if you think about this, maybe you can think that the erectile dysfunction is an independent marker of endothelial dysfunction and of early systemic vascular disease. And it's very common that you have a patient, somebody that it comes to your office, doctor, I have erectile dysfunction, my erection is not as good as used to be a few years ago, and then you see that you put a treatment on the patient, and then you see that this guy is having a myocardial infarction 2 years later, 3 years later. This is very typical. And it's so important to understand that is the reason why the treatment with the PD-5 inhibitor, let's say with Viagra, is not OTC, it's not a treatment over the counter. I remember that, this was many years ago when Pfizer lost the patent of Viagra. They wanted to have, because it was a very safe drug and there was no many problems with patients taking this. So they went to the European Medicines Agency to ask for move the prescription of Viagra to a non-prescription drug, so OTC drug. You can go in the pharmacy and take, or in the supermarket and take a box of Viagra. Why not? I mean, it was very safe. There was millions of tablets taken every day in the world. Why not? Because you are taking away the possibility of the patients to go to the doctor. You need to go to the doctor because this is a vascular disease. Erectile dysfunction is not just a, benign sign of other things. It's a warning sign, it's a sentinel sign of a systemic vascular disease. That is very important for you to understand. And many times the urologists are the gatekeepers of the vascular health of the patients. Okay, they come, and the first sign they have for a vascular problem, systemic, is erectile dysfunction. So you need to understand that. Look at this. I mean, it's a very simple study. It was 1,400 men from 40 to 75 years of age, and with no coronary artery disease. They didn't have anything, and they were followed during 10 years, okay? And the only thing they were looking at was, you have erectile dysfunction or not, okay? You don't have anything in the heart, you have erectile dysfunction or not. If you look at here, this is the number of events per 1,000 patient year, and you see how in the first row, 40 to 49, there is 48 events versus less than 1 in the group of patients, or the group of subjects with no erectile dysfunction. That is the difference. Okay, I'm sorry, I lost. Okay, so that is the difference. Of course, it's much important in the younger patients than in the older, because you have all the factors, and of course, age is important. But you see how big is the difference just having erectile dysfunction, okay? So if you have erectile dysfunction, the chances of having a coronary artery or a cardiovascular event is much higher than if you don't have that, okay? Very important to have that in mind. And erectile dysfunction appears to occur before the development of overt structural and functional systemic vascular disease. So it's very important to understand this, okay? So let's move to the guidelines. This is what I was saying. Let's go to the diagnosis. Diagnosis is quite easy. There's three things you need to do. One is a medical history, physical examination, and some lab tests, okay? These three things are enough for the 90% of the patients, okay? There are some patients you need to study a little bit more to clarify what is the problem, but for the vast majority of patients, any one of us can do this because it's clinical history, physical examination, and lab test. Of course, you need to speak with the patient to understand what is the problem. Why? Because many times, well, I don't know in your countries, but in my country, many times they confuse the things. They don't understand well what the difference between having an erection and having sexual desire or libido. You know, they don't understand. Sometimes they think, okay, because I don't have an erection, maybe it's because I have low libido, or I have a low sexual desire, I don't have desire anymore, things like that, you know. Many times they confuse the erection with the ejaculation. They have premature ejaculation, then they lost the erection, and they think there's a problem with the erection or the ejaculation, things like that, okay? So you know that these four areas in the sexual life. One is the sexual desire, the other one is erection, the other one is ejaculation, orgasm, and ejaculation. Okay, four, and you can have a problem with one of those without having any problems with the other. Okay, you can have an erection without an orgasm, or you can have ejaculation without an erection, things like that. Okay, so something you need to clarify with the patients. Identify what is the sexual problem of the patient. Many times they are not clear in their minds. Identify common causes of erectile dysfunction. Many times you discover that the patient has diabetes that the patient didn't know, or have hypertension, or other things that you are the first one to discover. Okay, you have to go to your GP because you have hypertension or whatever. Identify some of these factors that can be reversible, and then you try to treat that or send the patient to the appropriate doctor. And of course, look at the psychosocial status. There was something easy. I mean, it's not taking too much time to investigate. The patient is, having have a psychological problem mainly. For the majority of our patients, when you see a very young guy, normally it's a psychological problem. When you see a patient my age, you think it's an organic problem, okay? Because the age and the vascular risk factors are acting more in the older people, okay? So that was first thing, medical history. Second, physical examination. You have to check the penis for Peyronie's disease, for curvatures or any other problems in the penis. Prostatic disease, there's a correlation, or there's a relationship between prostatic problems and erectile dysfunction. Doesn't mean that if you have a BPH, then you have erectile dysfunction. Or if you have erectile dysfunction, you will have BPH. But they come together many times. They come together. There's a relationship, close relationship. So the probability of having one, if you have the other, is higher than in the normal population. Okay, so it's something you need to check. Probably the reason is not because one produces the other, is because they share the mechanism. Okay, if you have a hyper androgenic tone, let's say, then the smooth muscle of the penis is contracted, so you have more difficult erections, and the smooth muscle of the prostate, in fact, you treat BPH symptoms lots. You treat with alpha blockers, because they block the action of the alpha receptors. The alpha blockers could be of help in erection also. They are not very useful, but in fact, that is the mechanism that they share. There is a hypertonicity of the adrenergic tone, hyperadrenergic tone, okay? So there's combination of that, so you need to check that also. signs of hypogonadism. When you have low testosterone, you have less sexual desire, and that produces less erections many times. Okay, so something you need to check, and you need to look at that. Cardiovascular status, we will already talk about that. And we said the three things. The third is the lab tests. So you need to you need to check the glucose profile, and also the cholesterol, and you need to check the testosterone and all that. Okay, so it's not very difficult. That is for the majority of the patients, the vast majority of the patients coming to the office. There are some of the patients that you need to study more. For example, let's say a guy that is coming to your office saying, "Doctor, I never had an erection in my life. I never had a good erection. I always like soft erection, but was never hard. I thought it was normal, but when I started to have a relationship with a girl, I was unable to penetrate." What is that? There's an organic psychological problem. Young guy, why is having that? You may think, okay, this should be organic, but how you demonstrate that, how you study that? Any guesses? How? Okay, so we said at the beginning that we men have erections almost half of the night. Half of the night we are in erection. Okay, in the REM phase of the sleep, there's an automatic erection. That erections are important, are good for it's like gymnastics of the penis. Even though you don't have a sexual relationship or you don't masturbate in 2 weeks, then you still have erections every night, and it producing the inflow of blood with a high level of PO2, and there's some kind of gymnastics, as I said. Okay, if you don't have that, then you probably will end up with erectile dysfunction, and you can check that. There's a system called Rigiscan. I will show you how is the Rigiscan done to study this kind of patients, in which you don't know exactly if it's a psychological or if it's an organic problem. Or patients with a perineal trauma. You have a young guy had a motorcycle accident and a pelvic trauma, and after that he starts with erectile dysfunction. Why is that? Then you maybe need to check the cavernosa or the pudendal arteries to see if there is a blockage of the arteries, and then you can plan a bypass we do that with the epigastric artery to the arteries in the penis. Okay. Or patients with anatomical deformities, and then you need to check if it's an erectile dysfunction or just a geometric problem of the penis, things like that. Or patients with psychiatric problems and need to be studied by specialists and see if there's any treatment for that. Or problems with the endocrine system. These are the specifics that you can do. The Rigiscan will show you a picture in a moment. You can do vascular studies with a Doppler ultrasound of the penis, or you can do arteriography of the pudendal arteries, or you can do neurological studies to see if the nerves are not having the correct functioning, endocrinological studies, and so on. This is the Rigiscan. You check with this kind of halter of the penis, the erection in the base of the penis, or the patient takes this home for 3 nights, and then it holds, wears this at night, and at the sleep you see this kind of a graph. These are the erections, 1, 2, 3, 4 in these patients. You see this is 1 hour, so this erection will be like 1 hour and a half. This is the rigidity, and this is in the tip, and this is in the base of the penis. Then you can have an idea if the patient is having normal erections or erections that are not normal, or less amount of events every night, and so on. So you can decide if it's a normal pattern or not. If it's a normal pattern, then the problem maybe is psychological, why is the patient having erections when he's asleep and not when he is with his girlfriend? Probably because of a psychological problem. It's strange in a young guy that had never had erection, that is only psychological, but everybody has, all patients, all that I met in my life have also a psychological problem added to the organic problem. If you are my age, you have erection problems. Every time you go in a sexual intercourse, you are thinking, so my erection is not going to work, you see, or this pill is not going to work on me. You always have these kind of fears that it produces some anxiety. This anxiety, this performance anxiety is bad for the erection, okay? So everybody has that, but maybe in some cases, this is the only thing that they have, the psychological impact of that, or the organic problem is minimal, is very low, very small, and the psychological impact is so high, okay? So this is something you need to figure out with your patient and see what is the problem. This is the color Doppler ultrasound of the penis. You can check the vascular health of the penile arteries with the Doppler ultrasound. Of course, should be in erection. If you do this in flaccidity, it doesn't have it's not of help. So you need to produce an erection in the patient. How you produce an erection in the patient? You inject Caverject or prostaglandin E1 or Prostadil in the penis and then produce an erection and check the arteries when the penis is in erection. Okay, it's like a stress test for the heart. You put, if you look at the heart without exercise, then normally you don't see the problems. You don't see the difficulty of the arteries. You see that when you demand of the penis to produce an erection and see if the arteries are bringing the blood normally. Okay, you can check not only the inflow of blood. You see the inflow in the peak systolic velocity should be over 25 centimeters per second, but also the trapping of the blood. You can check looking at the end diastolic velocity. That should be less than 3 or 5 centimeters per second. Okay, if it's negative, it's better. But if it's positive, it should be less than 5, okay? So that is the way to check the trapping ability of the penis of blood, okay? These are the two things that are important. Of course, there are other that I'm not going to go for complete. This is the recommendation of the guidelines. You have the guidelines, and then you look at that, but it's basically what I've been saying. Okay, so let's go to the management or the treatment of these patients. Before you start with any kind of treatment, pharmacological treatment, then you try to identify if there is anything you can cure. Because for the majority of our patients, we cannot cure, okay? We can treat, we can manage, we can improve, but we cannot cure, okay? When can you cure? Well, for example, the patient that I mentioned before, the one that had a motorcycle accident with a pelvic trauma, problem with the artery, and then you you perform a bypass of the epigastric artery, and then you recover, that you cured the patient, okay? But it's a very strange case. Or you have a patient with prolactinoma, and then you find out that it has a tumor in the hypophysis, and then it goes to the neurosurgeon and recovers from that, okay? So that also a patient that you can cure. But the majority of our patients cannot be cured, okay? Can be managed. There's another thing you can do. You look at the patient and say, okay, I cannot cure this guy. Can I improve his lifestyle to improve the situation? And that is something you need to do, to modify the risk factors, modify in the sense of recovering from that. Some things you can do, of course, a patient with hypertension, you cannot modify that. You can treat the hypertension. Problem with the hypertension is that when you start the treatment, many patients start to perceive the erectile dysfunction, okay? If you lower the pressure in the patient, lose the inflow of blood in the penis, and they start to see, okay, doc, I was okay, and then I start to take the medication for hypertension, and then I start to have erectile dysfunction. Very typical, very typical. Of course, you need to tell the patient that, of course, you need to take this medication for hypertension, and we will treat that. There are some medications that are worse for the erection, like beta blockers or some diuretics. Some others are have less impact. But in any case, every time you lower the blood pressure, the rigidity of the erection is going to be less. You improve the health of the arteries, but still the impact is there, and many patients will notice that, okay? But in the long term, it's good, of course, to treat the erectile dysfunction. But anyway, it's important to do that. And also have a basic sexual counsel. You know, many times patients don't know what is normal. They are, watching porno movies, and they think, they have, particularly young people, ideas that are not real. Okay, so to speak with the patients, they dedicate some time to give basic sexual counsel. I think is important for him, for her, for the couple in general. Okay. Look, this is a very simple study also. This was a group of 110 obese men, so men that were too fat, over 30 BMI, and then with erectile dysfunction. Okay, so these were fat people with erectile dysfunction, and they made two groups, the young people, 35 to 55. And they were followed for 2 years, okay? And there was a group that they lost weight and exercise, and there's another group that was a control group, okay? Very simple study. And then you see how 30% of the group of patients that they were in the intervention group, they lost weight and they exercise, recover their erectile function, they get IIEF normal, versus 5% in the control group. Okay, so it's not too much, but it's enough. I mean, it's enough to recommend, okay, lose weight, exercise, control your diabetes, control your hypertension, stop smoking, things like that have an impact in the management of these patients, or are associated with an improvement in sexual function. Okay, so this is the management. Now you are finished with the improving the lifestyle, and then you say, okay, now, doctor, I need to treat, because the majority of our patients, of course, would not respond just to control and do some exercise. A guy like me, 62, fat, things like that, and then I'm not going to recover my erection because I do some exercise, okay? So I will need a treatment. What are the treatments? There are basically 3 lines of treatment. Because there are no way to cure that, you start with a treatment that is less invasive to more invasive. That is the only way that you treat these patients, the logical way to treat these patients, from minimal to more invasive treatments. What is the less invasive treatments? You think and you discuss that with the patient. You see that here in the guidelines are in the same row: intracavernosal injection, vacuum devices, oral therapy with PDE5 inhibitors, or topical prostatic. You discuss this with the patients. The vast majority of the patients will choose to start with a PDE5 inhibitor. Viagra, Cialis, Levitra, Spedra are the names of the 4 PDE5 inhibitors approved in Europe. Okay? There are some patients that prefer not to take a pill because they are afraid of having anything in the heart, myocardial infarction or whatever, and they're so scared about that they prefer to start with the intracavernosal injection. Or there are some old people that they don't want to start with the PDE5 inhibitors, and they prefer to start with a vacuum device. These vacuum devices, not very popular in the Western world, but in many, in the United States, a few that are using that, okay? Not very popular again in Europe. Or some of them prefer to start with a topical prostatil. But the efficacy is low, but this is a little invasive, so you can do that, okay? So this is the first-line treatment, or first-line treatment you can think it's a PDE5 inhibitors. Second line will be more invasive, the intracavernosal injection. On third line, more invasive, the penile implant, okay, penile prosthesis. That will be the logical way of treating these patients. In the middle, you can use other things. For example, low-intensity shock waves for the penis. They say there are some studies, not very robust evidence, but there are some studies showing that if you stimulate the endothelium with shock waves, then you produce angiogenesis and more vascularity in the penis and all that, and improve the erection. In my opinion, this is more a placebo effect, to be honest. Don't tell the people of the machines, Dornier and all that. But there's some studies showing some efficacy. And of course, as a young patient, you can start with this. It's very little invasive. You don't have too much to lose if you use that. Or if you use that in combination with PDE5 inhibitors, then the efficacy is good, okay? So PDE5 inhibitors, we saw this, the mechanism of action of PDE5 inhibitors. What you do is to block the action of this enzyme, the phosphodiesterase 5, in the smooth muscle of the smooth muscle cell of the penis, in the arteries and the trabecular, okay? So if you block 100% of the activity of this enzyme, and then you have a response, okay? So what is the most efficacious of these drugs? The 4 drugs that have been approved: sildenafil, tadalafil, vardenafil, and avanafil. All are the same. All have the same efficacy, because with any of them, at the different doses, can block 100% of the action of this enzyme. So the result is the same. So if you don't respond to one, it's strange that you respond to the other one, unless there are some other factors like psychological. You're afraid of this one, but this one is better. So why is everybody using one or the other? Depending on the other factors, like the pharmacokinetics of the drugs are different. The Tmax, so the time that it takes the drug to reach the maximal concentration, not all are the same. Viagra, sildenafil is 1 hour, tadalafil is 2 hours, so you need to tell the patient, okay, you take the pill, and you need to wait 2 hours if you take tadalafil. If you take sildenafil, is 1 hour. If you take avanafil, is half an hour, okay? So one is quicker. The other one, the other parameter that is important is the half-life. So the time that the half of the concentration is lost, let's say. So normally the efficacy is double the half-time, of course. So you have sildenafil is about 4 hours, 3 hours, so the efficacy extends in 6-8 hours. If you look at the tadalafil, is almost 18 hours, so the efficacy extends for 36 hours. So it depends on the sexual habits of the patient or the couple. Then you tell the patient, okay, you can take this, and you go almost the whole weekend with this, or you have one sexual encounter every 15 days. One pill is enough, and you discuss this with the patients. Also, the side effects have a relationship with the half-life. If you have side effects, and then it will last as much as the half-life, probably. It depends on the patients. It depends on everyone. It's very, some patients have this or have the others. Because this is another important point, the side effects profile, because not everybody has the same, all the side effects. You see here, there's some side effects that are class side effects. Headache is almost universal. Some of the drugs are producing more headache, some of the drugs are producing less. Abnormal vision, for example, is more common with sildenafil and is not common with tadalafil, but tadalafil has back pain and myalgia that is quite common, so sometimes they have this type of problem. There's also something you can understand. You look at this. the half-life is that you have a half-life that is so long that if you tell the patient, okay, take a pill every day, the second day you don't have zero in the plasma concentration, you have something. So this, if you take a second day in 24 hours another pill, and 24 hours another pill, you go up and up and up, and there's accumulation in blood. What it means that if you take a low dose, like 5 milligrams of tadalafil instead of 20, you will reach the plasma concentration of 20, but taking a pill every day, and you are covered all the time, which is good for some patients. And maybe it's also good to improve the erections that you have when you're asleep, okay? If you're sleeping and you have a PD-5 inhibitors in your blood, then the erection is going to be better, it's going to be longer, it's going to be harder. So probably the oxygenation of the penis, the tissue, is going to be better. So maybe it's a good thing for rehabilitation of some patients, or to start with treatment. In some patients, young patients, you start with a daily dose treatment, and you are covered all the time. Also good because it's like having your cell phone always on, okay? You can make calls and you can receive calls even during the night, you see? So you're always ready. And it's good for some young people that they cannot program, or they don't have or they have a common frequent sexual life, and then they're not, thinking about, oh, I didn't take my pill, or things like that, okay? So it's helpful for some patients. You need to discuss this with the patients. Also, the PD-5 inhibitor, tadalafil, taken every day, has been approved for the treatment of LUTS, okay? The efficacy of tadalafil taken every day is the same as if you're taking tamsulosin. Many studies showing the same efficacy in terms of improving the symptoms and improving the Qmax. So it has been approved. The problem is that there's not reimbursed in many countries. So if you tell the patient, okay, you're going to treat the LUTS with tadalafil, it's going to be expensive, unless the patient is having both things and is willing to treat both things. Because you know that many drugs for LUTS are having sexual side effects, and you avoid these side effects with this treatment. So it's an option, and you can use that, okay? This is there's no difference in terms of efficacy, there's no difference in terms of preference of the patient. The possibility of taking daily this is an alternative to some patients, and also in the comorbid patient of BPH, LUTS, and erectile dysfunction. Okay, intracavernosal therapy is more effective than PD-5 inhibitors, more effective. Almost 85% of the patients still have some reserve to respond to that, so it's, again, more effective. The problem is that more invasive. So you tell the patient, okay, you have to inject your penis every time you want to have sex, and they maybe accept that at the beginning, but then when they have, 6 months with this, they say, oh, doctor, I don't want to do this anymore. This is a pain it's not painful, but it's a problem to be all the time with that. Particularly, they don't have a stable couple, and it's terrible. So they abandon this. The abandon rate of this treatment is high. It's almost 70% in the first 2-3 months. Okay, you can combine this also with the PD-5 inhibitor, because the prostaglandin E1 is not acting, it's producing a relaxation of the smooth muscle, but not through the nitric oxide cyclic GMP pathway. It's using the AMP pathway. It's a different one. So if you use both, you can have a synergistic effect. You act and you produce relaxation of the smooth muscle through 2 different pathways, and there's a synergistic effect. Maybe with the injection is not, it's too much, but if you tell the patient, okay, use prostaglandin, topic prostaglandin, maybe it's a good combination, and it's quite common in my country. In Spain, it's quite common to use both things. The PD5 inhibitor, patients not responding, of course, not responding enough. Taking PD5 inhibitor and topical prostaglandin treatment is quite effective. Of course, it's more expensive, and many patients don't want to spend so much money with that. Okay, this will be the way of injecting the Caverject is the name in many countries. In other countries, it's Viridal in northern countries, I think. And it's quite easy. You inject in the base of the penis. You don't use, of course, the glands or the urethra, or you don't inject in the upper part when you have the nerves, the cavernosal nerve. I mean the dorsal nerves and the dorsal arteries and the dorsal vein. So you inject in one side and put the medication in one of the corpus cavernosum. Because there's a communication between them, they act like a syncytium. And you inject in one place, the direction is global, of course, in the penis. So this will be the first choice of these vasoactive drugs, Prostadil, and in fact is the only one that has been approved as a medication in the majority of the countries. There's some countries that have a combination, but if you have a short response, then you can combine with alpha blocker, phentolamine. You use Prostadil plus, so it was a relaxant of the smooth muscle with an alpha blocker that blocks the action of the alpha receptors. Then you increase the efficacy of that. Or two different drugs like Prostadil or papaverine, or combination of the three. But it's making the life of the patients more complicated because they have, this is not marketed. You need to go to the pharmacy when they make this formulation, and it's complicated again. Maybe in the United States it's more easy because in the hospitals they have the pharmacy that make these kind of combinations, and they provide this to the patients, but not in countries. In general, in Europe, the drugs are sold in pharmacies, and they don't do that. There's only a few. Okay, topical Prostadil, I spoke about that already. Penile prosthesis. Penile prosthesis is a treatment that is very efficacious, always working. The only thing is that it's more invasive, so you need to convince the patient that it's worth to have an operation, to run the risk of having a complication, which is rare, but is there. The rate complications is very low, but you can have, if you don't have enough experience with that, you can have a complication. I will show you a small video of a penile implant. It's something that every one of us should know how to do because it's easy. We do more difficult surgeries than implantation of a penile prosthesis. The only thing is that you need to be used to that. Low intensity extracorporeal shockwave therapy, we spoke about that. The efficacy is so and so. Penile prosthesis, as I said. Okay, so let's see the video of penile prosthesis. First thing you do is you prepare very well the skin. You empty the bladder and you put a plug in the Foley catheter. And normally we use this retractor. It's called Scott retractor. Scott retractor is very helpful because you just make a very small incision, and through this incision you implant a three-piece penile prosthesis. Okay, so you use these retractors with the elastic hooks that keeps the wound open, makes your life easier. Then the only thing you need to be careful is the urethra. So you have a bladder catheter, you identify the urethra, you don't want to damage the urethra, and then you just remove the Buch's fascia to reach the white cavernosal, the tunica albuginea. Tunica albuginea of the penis is white, and then you place some stay sutures Now, that is useful because then you don't need to go with the needles when you have the implant, the cylinder inside. You don't go with the needles to close that. We use that to close the tunica albuginea. Okay, you see the cavernosal tissue inside is very spongy. Is very easy to dilate. So that's why we published many years ago, like 12 years ago, the use of no dilatation. Okay, this is the insertion of the Furlow's measurement tool. So you measure, you say, okay, this is 10 or 12 or 15, and then you go in the back, and you reach the bone, and you say, okay, this is 7 or 8. And then you make the addition. It's like a 23 measurement. Okay, so there you use the penile implant. That is this was the publication in Journal of Urology a few years ago. And then we always use the antibiotic to flush that and to to cover the staph epidermidis, which is the main contaminant of this. I always tell my patients that if they have an infection, is my fault because I was not clean enough. If you have an infection and the penile prosthesis is sterile in the box, and then you close the skin, or is contaminated during the implantation, there's no way that you have an infection. Okay, and also we use the penile prosthesis that are covered by antibiotic. That is eluting the antibiotic in the next 15 days up to the implantation, the surgery. So again, this is the other side. We do the same operation. We dilate the distal, proximal, and then we figure out what is the appropriate length of the penis. I tell the patient, because they always want to have a longer penis as possible. I say, okay, I will put the one that you need. It's like you are going to buy a shoes. You don't buy, if your number is 40, you need to buy a 40, no 43 or 38. I mean, then you prepare the device, remove the air, and this is the reservoir, 3 parts, cylinders, the pump, and the reservoir. This is the reservoir, cylinders, and the pump is in the scrotum, okay? So I like to use this half moon shape. It makes my life easier when you are putting that through the inguinal ring. So that the reservoir goes in close to the bladder in the prevesical space, in the retius space. Okay. So always try to avoid any contact of any part of the prosthesis with the skin of the patient. There's always a staph epidermidis or staph aureus that they produce the infection. Okay, so the prosthesis is not touching the skin as much as possible. There's always a small touch, but then I was responsible to prepare the skin and to use the antiseptics that best alcoholic chlorhexidine preparations for the skin. Okay, so you use this tool to bring this thread in the distal part of the corpus cavernosum that helps the distal part of the cylinder to go in the at the end of the corpus cavernosum. Otherwise, there is no way to bring the tip up. And then we go with the back part, the crural part of the proximal part of the prosthesis. You see that I'm very careful with the skin. I don't want the prosthesis to touch the skin, and then I push, and it's reaching the place, and then I tie the sutures that I placed before. Okay, so that you don't go with needles and having the chance to perforate the cylinder. If you do that, and then the prosthesis is not working, they say, "What's going on, doctor? I mean, this is not working," because you perforate the one cylinders without noticing. If you notice, of course, you need to change the prosthesis in that moment. Okay. So you do this, and you do the same thing in the other side. Okay. This is the right side of the patient, and you go in the left, and you tight that. So you have the cylinders and the pump that is pre-connected. Then you take your pump with your hand, to avoid any contact and remove the reservoir, the retractor. And you place the reservoir, okay? So you remove everything. The pump is in my hand, and then you remove retractor. And then you use the inguinal ring to place the reservoir, okay? You put your finger that you are trying to explore. Okay, so the first thing we do is to place the pump, because I don't want to be with the pump in my hand all the time, okay? So I make a space here in the scrotum. I like to make a space in between the testicles and in the lower part. So the patient is standing and there's no, you don't see the pump, okay? You don't touch the pump. Okay, so you take that, the dartos of the scrotum, and put that in the middle. So the testicles will be in the upper part, and the pump in the behind the testicles. That is, you need to have that easily reached by the patient. Okay, so that is the pump, but is in behind the testicles in the upper part. Okay, and now I take the dartos again, and I look for the inguinal ring. I put my finger like trying to explore inguinal hernia, and to touch the inguinal canal. Okay, the floor of the inguinal canal is the transversalis fascia. You pierce the transversalis fascia with the tip of your scissors. I mean, this is the complete scissors inside. That is dangerous. Only the tip, okay? Tip of the scissors. You pierce the transversalis fascia. You make a bigger hole with your finger and place the reservoir there. You don't need to make too much space, because when you fill up the reservoir, it will make enough space. There are two reservoirs, 100 cc's or 65 cc's. I normally use the 65 is enough. This is the 65, but I will show the CT scan of. Okay, so you insert the reservoir, and then you fill that. When you fill the reservoir, you don't need to close that hole, because it's full. Impossible to remove, okay? And then after a few days, the body will create a capsule around every part of the prosthesis and around the reservoir, so it will not move. The only thing is that you need to be filled up with saline. We use saline, clean saline. This is the reservoir, and you see the bladder also there. So it's in the retro space, and you put that through the inguinal canal, piercing the transversalis fascia. So everything is already in. You just clamp the tubing and make the connection between the pump and the reservoir, and then you check if everything is working well. You use this tool to make this connection. Check that is firm and it's not going. Okay, and then you just close the dartos first and the skin later. Or you can check the erection here. You try to see if the penis is straight or there is any deviation of the penis, and then you, because sometimes the patients have Peyronie's disease that they don't know, or the cylinders are not are placed in the right place, and then one that is longer than the other, or whatever. Then you check that. You check the erection, and you check the flaccidity, and it's fine. And then we leave the prosthesis a little bit inflated, because it will avoid the hematomas. But still, we always leave a drain. Always leave a Jackson-Pratt drain. Okay, there's some protections here that I also remove. Put a drain, and that is all. Okay, and then close. So this will be the typical patient with a penile prosthesis. This is an MRI of the prosthesis. It's a natural flaccidity. This is what the patients want because 99% of his time is going to be in flaccidity, so you want to have something that is not problematic. Still, you need to tell the patients that they will have in flaccidity a longer penis that they used to have because you have the cylinders there that are, they go a little bit longer and of course thicker, but not so much small, okay? So if they are in the locker room or in something like that, they will see that the penis is a little bit bigger, okay? But for the majority of the patients, they don't care about that. They more worried if it's too small, they don't like, okay? So just a few words. That is the penile prosthesis. I don't know if you want to make any questions or any doubts about that, the surgery. Again, I think this is a quite easy surgery, and you, as urologists, need to know how to do this. Very simple procedure, simpler than radical prostatectomy or whatever. Things are much more difficult, cystectomy or whatever. I mean, this is quite easy. The only thing is that you have to have your principles in mind, particularly the asepsis when you are doing that. You do it very clean, do it in a systematic way, step by step, and if you do that in a right way, there's no complications whatsoever, okay? So the number of infections should be very, very low, less than 1%, okay? You see the numbers there, and sometimes it's too high, okay? So just a few words about the erectile dysfunction after radical prostatectomy. You know that radical prostatectomy is removing the prostate because of a prostate cancer, that is a localized prostate cancer, and you can damage the nerves that are taking this signal to the penis, okay? The nerves are in the neurovascular bundles are in the sides peripheral of the prostate, and you can damage that when you're doing the surgery. Precisely because that is the use of robotic surgery, because robotic surgery claims that you can preserve in a better way the neurovascular bundles, so you have less chances of having erectile dysfunction. Still, it's quite common, and it's more common than many series are published, okay? So everybody is saying, no, I have 80% of recovery of erectile function. Probably that is not true. In the majority of the cases, there is always some kind of erectile dysfunction. Always there's some erection that is lost. Sometimes it's recovered. What is the main thing that it depends on the recovery, apart from the surgery? Of course, surgery is number one. If you cut the nerves and you take a part of the nerves, it's done. I mean, it's not going to recover. It's like you cut the light, wires. There's no way to recover. But if you preserve that, if you try to preserve, because many times you don't see, because it's not like this, it's not something you see, it's just a veil of nerves there. If you try to preserve, the number one thing that is impacting the recovery of the erection is the age of the patient, the erectile reserve. If it's a guy of 50 years of age, they will recover. And if it's 75 years of age, probably not recover. It depends on the erectile reserve. Even though many times the patient comes to your office and says, no, doctor, I have a good erection, I don't have problems with my erection, the reserve is very low. And because there's something that is lost, they probably don't recover. I always tell the patients my example of what is the reserve. And I tell, when I was medical student in Madrid, I used to have a Vespa, the Vespa, the scooter. Okay, there was many years ago, and there was no gas needle. I mean, I didn't know what is if the tank was full or is empty. I mean, I didn't know that when I was running with my motorcycle and then start to make this type of movements, and then it was almost in the reserve. I opened the key of the reserve, and then I knew that I had to go in the gas station, okay, to put more gas. But 5 minutes before that was normal, was running okay. That is what I mean with that reserve. The reserve is small, but still was working. 5 minutes before that was normal. 5 minutes after was not running, okay? And you have to open the reserve and put more gas. So that is what I mean. If you have 75, even though you tell me that your erection is still normal, probably you have very little reserve, and the surgery is going to make you reach this low reserve that is not going to recover, okay? So something you make clear to the patient. So age is number one, of course, the quality of the erection before, and the age of the patient, again, is the key determinant of that. But there's always some damage of the nerves, because you need to peel out the nerves, to peel out that tissue, and that gesture of touching that is producing some damage that it can be recovered, the neuropraxia that can recover or not so much, okay? So that is key. There is anything we can do to improve that? Because there's always like 18 months that you can tell the patient, okay, you have this time to recover. Of course, you have the time also fighting against and pro. I don't know what happened here. This is not mine. Okay, so the patient is getting older in one side, and the other side, they're recovering the neuropraxia, okay? So you can tell the patient, okay, if 18 months after the surgery you didn't recover, you won't recover. Anything we can do? Maybe you can give PD5 inhibitors, but PD5 inhibitors is not doing anything in the nerve recovery. Is only using the small amount of nitric oxide that a patient is releasing at night or is releasing when have a sexual stimulation to improve that and to increase the inflow of blood in the penis and try to avoid the atrophy and the fibrosis of the tissue. So this is the only thing you can do. There's no way that you can improve the neural regeneration, but you can preserve in some way the endothelium and the vascular, the health of the tissue, okay? So what we do is we give a patient PD5 inhibitors. There's no evidence that if you give a patient PD5 inhibitors on demand, every time they want to have a sexual encounter, is worse than giving tadalafil every day. You can do whatever. I normally do a PD5 inhibitor daily dosing. I think it has a positive effect on the nocturnal erections, and at the end of the day can have a better response to that. So I took too much time with this. So I don't know if there's any questions in this part. Yes, there's microphones. I think. You can use this one. Thank you, but I'm not done, eh? You're not done with me yet. So I'll speak a little bit about Peyronie's disease and then priapism, okay? Just practical things. Yes, your question?
Yes, I would like to ask about if you perform a blood test in the initial study of the patient, especially the testosterone levels.
Say again, I didn't get the sound is not very good here.
I'm asking about the study of testosterone levels in the initial study of the patients.
Yes. There's a recommendation of the guidelines that you do a testosterone study. Normally, we ask, and the guidelines say total testosterone, but you can ask also free testosterone on the globulin that is transporting the testosterone, okay?
And you perform it in
sexual
every
hormone
patient?
binding globulin. Same?
Every patient?
In every patient, yes. I do that in every patient, yes. I think it's quite simple, it's quite cheap, and gives you idea of the testosterone levels are normal. Of course, if the patient has low sexual desire, low libido, but I think in the complete study of a patient with erectile dysfunction, is not, it's not so expensive, and then you ask that, you ask glucose, lipid profile, testosterone, and all that, okay? So I'll do that, and the guidelines say that is recommended.
My question is that what specific advice you give to the patient after doing the penile prosthesis?
What specific advice?
Yeah. Or precautions?
Well, once you had implanted the prosthesis and you see the patient, I see the patient next week, okay, in 1 week, even before, and I check the penis, I see if there's any sign of infection. Normally you have that. If there's any hematomas or something like that, the patients always like you to check up on them. And if everything is fine, I tell the patient, okay, come in 15 days. In 15 days, this is 3 weeks after the surgery, I start to pump the prosthesis up. They complain because it's a little bit painful. Every time you implant anything in the body is producing a capsule, okay? A capsule around the foreign body. There's always, that is automatic. If you implant a breast implant or whatever, it's producing a capsule. And the capsule, while is producing, is painful, feels like pain, okay? You touch the prosthesis and it's painful. You touch in the scrotum and the pump, it's painful. But of course the pain is going out. And then they complain and say, it's painful, doctor, please don't touch, not too much, but you always like to check a little bit, and then you tell the patient, okay, after 5 weeks, normally 4 or 5 weeks, 5 weeks I think is more normal, the patient is coming, there's no pain, and they start to check that, to use that. I always give the patients a pump that they can, it's like a key holder, a pump, and they know how it is, the shape, and they touch, and they check how it's working. There is one part that is you pump, and there's one part you deflate, so they learn how to use that. So I do it personally. There are not so many patients that are having penile implants, and I think it's good to have always care, very, very personal care of the patient.
You use normal saline for the reservoir. Don't you think it's there for quite a big time and it wouldn't crystallize, or you can use any other fluid instead of normal saline?
No, I think, because the prostheses are, you need to put something that is osmotically like blood, okay? Saline is the best thing. If you use something that is hypertonic, then it will fill with more fluid, okay, from the body. If you put something that is hypotonic, it will, or the contrary. If it's hypertonic, it will lose, whatever. So you need to use something that is iso-osmolar with the blood, okay? Saline is the best thing, and it's, of course, it's sterile. But it's a closed circuit. You don't need to change that, and it's always, for life, is the same thing. The only thing is that sometimes, maybe in 10 or 15 years, some prostheses are broken, okay? Because it's a physical thing that if you use, maybe it can break, so you have to change that. And we do that every now and then. We have to change the prosthesis. But for the majority of the brands, prosthesis brands, I use Boston Scientific, but you can use Coloplast or any other. They give a life guarantee, okay? So you tell the patient, okay, if there's any breakage of the prosthesis, then the company will give you a new one without charge. The surgeon will be charging you, of course, and the hospital.
Do you think there is any advantage of giving PD-5 inhibitors as early after nerve-sparing radical prostatectomy?
Early.
Yeah.
Well, I think so. I I remove the bladder catheter in 1 week until my patients start to use the PD-5 inhibitor, tadalafil, every day. The same day that I remove the bladder catheter, 1 week after the surgery. I think it's two things. I mean, one, even I start the treatment before the surgery. Because starting before the surgery, there's always an improvement of the erection. I mean, any one of us, or maybe but I mean, patients are going to be submitted to radical prostatectomy, will perceive the improvement. If I take tadalafil 5 milligrams a day, even though I didn't have the radical prostatectomy, I improve my erections and my nocturnal erections. I feel that when I wake up in the morning, my erection is harder, okay? That is preparing in some way the tissue to resist more the period of, this period of erectile silence. There's always a silence after the radical prostatectomy. So sometimes I start before the surgery. That is good because they understand what is the way of taking the pill. They are aware of the erection, and they understand what is all these mechanisms. And they also learn the side effects and all that. So because sometimes they become, when you start after the surgery, they are a little bit afraid of, I have pain here. Is that because of the medication, or I have whatever, a deep vein thrombosis or whatever, So I think it's a good thing to start before the surgery. But for the majority of the patients, I start the week after surgery, 1 week after surgery. I think there's an advantage of that.
Do you put two-piece implants as well? And if you do, then what are the kind of patients where do you prefer two-piece implants over three-piece implants?
Two-piece.
Yes.
Okay, two-piece implant, that I don't like too much. Why? Because you can tell the patient that is something in between full erection or full flacidity, but you don't have both, okay? So I want the patients to have full flacidity and full erection, and you get that with three-piece because you fill up the cylinders with a lot of fluid, okay? Two-piece, meaning that you have the cylinders and the pump, and there is no reservoir. So there is a very small amount of fluid in the system. So you press the pump a couple of times, the small amount of fluid that is in the pump goes in the cylinders, and of course becomes a little bit harder, but not complete. Okay, so I don't like that very much. I don't use that. So what you see, okay, but you have the advantage in a patient after radical prostatectomy. Yeah, you don't go in the retro space because there's surgery there, and it's going to be more difficult to put the. But it's not true. I mean, I have done many. In fact, is probably the number one reason that we implant penile prosthesis is radical prostatectomy patients. Okay, because our young people that they were in the majority well in terms of erection before the surgery, and then suddenly they lost the erection and they, not so happy. I mean, it's not the same that an old patient that is getting old and is losing, slowly the erection. This is something that happens in a moment after the surgery. So they don't like that. And this is number one reason for implantation. So you can do that, the reservoir, even in patients after radical prostatectomy. The only thing is the transversalis fascia is thicker. It's a little bit harder, and it takes a little bit more to perforate that. Be careful with that. It's also happening in patients after radical prostatectomy and radiotherapy. Okay, you have a patient that had a radical prostatectomy. Let's say they recover more or less the erection, they are quite happy, and then they have a PSA relapse, and they have to have radiotherapy, and then they lost the erection completely, because radiotherapy is not good for erection at all. Okay, so they lose the erection completely, and then it comes for the penile prosthesis, and it's more difficult, not only because of the surgery, but also because of the radiotherapy. So you need to be extra careful with that, because it's not strange that they put in the scissors and you damage particularly the iliac vein. And I haven't had this, but I have seen this a few times in some colleagues that had this problem. And I remember one, there was in a live surgery in a course. They put the scissors in the iliac vein, and there was a mess, okay? So bleeding a lot, a lot. And you have a small incision, you have to make another incision, a big one, and then go to close the vein. It's a mess. So need to be extra careful. But this is the only thing. And now you have another alternative. There is a reservoir that is not round, like we saw, is flat, okay? It's flat. Then you can go in the transversalis fascia. So you put the finger in the inguinal ring, and you touch the transversalis fascia. Here up, you have the rectus muscle, okay? Down is the transversalis fascia. If you go with your finger, go up, below the rectus muscle, you can place the reservoir there. It's called the ectopic placement of the reservoir, because it's flat, it's not producing any bulging in the abdomen, okay? And you can use that in patients after radical prostatectomy or after radical cystectomy. After radical cystectomy, I see my friend Sax Minhas here. Let me finish with this. After radical cystectomy, is more difficult to do that blindly, because you have bowels there, okay? So you don't do that blind from the scrotal incision. You need to make another incision or place that ectopically. Sax, good morning. How are you?
Very good, thank you.
Happy to see you.
Very, very happy to see you. I'm sorry I'm not there in person.
We are missing you here. There's a good bunch of people here, eh? Watching you.
That's good. It's good. You can see all my blemishes.
So we talk about the erectile dysfunction, and now we are going to speak about penile curvature, Peyronie's disease, and priapism, and we'll have a coffee break, and then you will start at 11, okay? Is that okay? Well, I don't know. Should be okay. Okay, so there's not any more questions? I will follow. Okay, there's one more. Last. If I detect androgen deficiency, what else? Do you use testosterone therapy? Yeah, of course. But my colleague, he will speak about I will speak about the hypogonadism, okay? But if you have a patient with erectile dysfunction and low testosterone, you treat low testosterone and also treat erectile dysfunction. Or you can use the testosterone first and see if they recover the erection. You can do both. Happy with that? Okay. Okay, so let's be very quick with the next two topics. Please, can I have my second presentation? Okay, penile curvature. You have two kinds of penile curvature. One is congenital, let's say. Normally the penis is downwards. Why is happening? Because there's a disproportion between the parts of the penis. The corpus cavernosum are longer, the urethra is a little bit shorter, and they produce this kind of curvature. Normally is, of course, for life, and the only treatment for that is surgery, okay? So you do application of the dorsal part in this case. This was, by the way, urology resident. Had this kind of curvature. I mean, you can live with that, but many times they don't like too much. The only thing that is when you do this kind of surgery, you shorten a little bit the penis. Okay, this is called the Nesbit operation. You remove a small piece in the dorsal part of the penis, a small piece of tunica albuginea, or you make a plication. You don't remove, but you do a application. In any case, you just shorten the dorsal part, so the penis is straight, but by definition is a little bit shorter. But normally these are longer penises, so it's not a big deal. Okay, Peyronie's disease is a different thing. It's an acquired penile curvature. Okay, the penis is normally bent upwards, okay, not downwards, but upwards, or one side, or the other, or had other deformities. This is due to fibrosis in one part of the penis, okay, in one part of the tunica, fibrosis. Why is this fibrosis produced? Normally, the pathophysiology, physiological mechanism that is, everybody is agree on that, is that it's microtrauma in the penis. When you have a trauma in the penis, normally when there's an erection, otherwise you can bend the penis and there is no trauma, okay? If you have an erection and you bend the penis, you can damage the tunica, okay? If it's a very strong thing, you can break the tunica. You can produce a tear in the tunica. That is a penile fracture, okay? Penile fracture, there's a big hematoma, the erection is lost, and the patient is coming to the emergency room, say, I was having sex and I perceive a crack in my penis, and look, what is that, okay? And that is, you need to do surgery, okay? You need to close that. You need to open and close that. This is a penile fracture. But other times, the trauma is not so strong, it's small, it's micro trauma, okay? Normally, when the man is having sex lying down and the couple is on top, okay? And producing that type of bend, and if you are genetically predisposed to that, you can have a fibrosis, okay? At the beginning, there is like a lump, a small nodule that is painful, and then there is a fibrosis. The fibrosis produces lack of elasticity in that part of the penis, and that lack of elasticity produces, when you have an erection, a bend, okay? That is Peyronie's disease. There are two phases that are very important to understand, two phases. One phase is acute phase, and then there is a stable phase. Acute phase, important to identify. Why? Because if you do surgery in acute phase, the typical thing is that it's progressive, okay? It's a progression of the bend. You don't do surgery in the acute phase, okay? You do all the treatments that are conservative, but not surgery in acute phase. Otherwise, you find that the patient, you do the surgery, put the penis straight, and then it's coming 6 months after, doctor, and the same thing that it was 6 months ago, okay? So you don't, this is the typical progression of Peyronie's disease. So you can see, this kind of bend that is too much, okay? Then you have to go into surgery, okay? So two phases, active phase. How you identify that? Because there's still pain in the penis when they touch the nodule, it's painful, and the erection is painful, and there's a progression of the deformity. There's not stable yet. In the other phase, the disease, there's no pain, and the curvature is stable. It's not worsening anymore, okay? In the active phase, you can use some kinds of treatment. In the stable phase, when it's finished, you need to ask the patient if there's any troubles with that. If it's a small curvature, Peyronie's disease with a small curvature, is able to penetrate, is able to perform, you don't need to do anything, okay? If it's not able to perform or is complaining about the shape of the penis or whatever, then you can do surgery, okay? But it is important to understand that this disease of the penis, you cannot recover from that. Or you can tell your patient, okay, your penis is never going to be like it used to be before the disease, okay? Impossible, impossible. Surgery is not going to leave your penis perfect. Never. It's not like before, okay? So understand that, because it's There's it's like you have a scar in your face. You have a scar, and you have a scar for life. You can make a surgery and improve a little bit, but still you have a scar, okay? So if you take a scar, to take out a scar, and then there's another one, okay? There's no possibility to leave that as used to be, never. Okay, so what do you do in active phase? There's some things you can do. You can inject medication, or you can do that also in the stable phase, but there's a few things. You see here in yellow is a number of things that are not useful. Everybody is giving vitamin E, whatever, many things. Tamoxifen, carnitine, not useful. Don't use that. There's no response to that, okay? Antioxidants, whatever. No, it's not working. There's only a couple of things that works. One is the injection of a collagenase, something that dissolves the collagen in the fibrosis, okay? You inject something that is softens the fibrosis, okay? So you can use that. Particularly in the stable phase, because the fibrosis is already there, but also in the active phase. When you have fibrosis, you can dissolve that. You can help that to be not so thick, okay? And that is working not so much, and is very expensive. So there are many of us that are not using that unless the patient is willing to do that, because it's expensive and the efficacy is so and so. The second thing you can do is to use a penile extender, something you can keep the penis in a stretch, then that reduces the fibrosis and lengthens the penis a little bit, and in some cases can be useful. This is the injection, quite difficult to insert the medication inside the fibrosis. This is the plaque, okay? So you need to inject that inside, and it's quite expensive. These are the number of cycles you need to do, and this is the efficacy. Not so much, okay? Compared to placebo. Compared to placebo, this is the difference between the Xiapex, and this is the placebo. There is a decrease, but not compared to placebo, not so much, okay? Quite expensive. These are the studies that are published in penile traction. You can use this kind. This is the Spanish penile stretcher. This is the German one that I like more. Not personally, my patients, but we published this. We published this in the British Journal of Urology. This is what you can expect from the typical patient, okay? This is the penile curvature, and this is at the end of the 3 months of treatment. The penis is not completely straight, but is better than it used to be. And then you can make surgery, easier surgery, because and this is another one that is a new one that is in the United States called Restorex. That we don't have that one, but you stretch the penis and they bend the penis in the opposite side of the curvature. Okay, I don't know exactly the efficacy of that. So what is the surgery? Only again in the stable phase depends on two things, or several things. One, erectile dysfunction. One of the main cases, main reasons for penile implants is Peyronie's disease. Number one is radical prostatectomy, in my case, in my experience. Number two, Peyronie's disease. Okay, there's a lot of people now implanting penile prosthesis in patients with Peyronie's disease without erectile dysfunction, because they say, okay, you are going to have that, and that is the best treatment for that, okay? And doing other type of surgeries is less predictable, the result, okay? So, but anyway, what the guidelines say, if you have erectile dysfunction, you go in the penile prosthesis way. If you don't have that, then depends on a few things, depends on the length of the penis and the degree of curvature. The longer the penis and the less the curvature, then you can do application, a surgery that is less aggressive. If you have a small penis or very severe curvature, then application will be or plication or Nesbit will be, the result will be bad because the penis will be short, the patient will not be able to perform sexually. Then you have to propose the patient to lengthen the short side, okay? And that it means you put a graft in the penis, okay? This will be the way to do the plication. You can use this technique, the 16 dot, whatever. It's in the guidelines. Or you do the grafting. You cut in the short side, so there's a gap there, and then you cover the gap with many different materials you can use. I've been using a lot the buccal mucosa, but you can use many things. It's also quite common to use now Tachosil. Tachosil is, it's a different kind of, it's not a graft itself, it's just a collagen fleece that you put on top. We'll see that in a moment. This is the buccal mucosa graft. Can we advance this a little bit? Because we are short of time. Okay, so you make a circumcision incision and you deglove the penis, you dissect the neurovascular bundle here in the dorsal aspect of the penis because you don't want to do the surgery. Put a tourniquet, check the erection. There's a lot of people putting the needle directly in the cavernosal body. I prefer to do it through the glands, because through the glands, if there's any bleeding, it goes, the blood goes in the glands and there's no hematomas, okay? Okay, so you dissect that, normally with the help of loops. You don't want to damage the dorsal nerves and leave the penis or the glands completely numbed, okay? So you dissect that, and then you check again what is the erection and what is the curvature. When you figure out what is the place of maximal curvature, then there's a very nice publication of Paulo Egidio, this Brazilian guy, that made this study of geometric calculation of these arms of the incision, that it should be the difference between the short side and the long side. Okay, if it's 4, if this is 10 and this is 14, it's 4 centimeters. The sides of these legs should be the width of this legs should be 4 centimeters. And then when you have that and you undermine a little bit to leave a place, then you measure and say, okay, this is 4 on this side and it's 3 on the other side. And then you take a piece of buccal mucosa to cover that defect. Buccal mucosa is something we normally take for the urethra, so it's quite easy to do. Then you close the defect in the mouth. You remove the fat and leaving only all the layers of the mucosa, and then you put the graft in the penis, okay? So that is the... And this is the surgery. This is the thing you put. You use 4 sutures, 1 in each corner, and then close in a continuous fashion. And then you check the erection, and you check if it's completely straight. Normally, because this is leaving the surface of the penis not completely smooth, it's a little bit uneven. I like to cover everything. You see, there's no completely even. Then you, okay, we check the erection again. It's nice, it's straight. And then I cover this with this thing, which is called Integra. It's like artificial skin, okay? It gives the surface of the penis more soft and more smooth, let's say. And Then when you finish that, you just cover you put the skin again in the place, okay? Okay, so this is the one surgery. This will be the other one. Can you play this? The use of Tachosil. Now we are using that more, the Tachosil. This is, was more popular after the publications of a German urologist with a Greek name, Hachikristodoulou, that was using this very much, and he convinced the majority of the people to do this, and it's quite easy because you don't need to take anything from the mouth or whatever. It's quite easy. You don't need to put the stitches even. You just put this fleece. You probably have been using this in other surgeries for bleeding in other parts, or to cover things. I mean, it's just put that, open the tunica albuginea and placing this, and that's the surgery. It's very easy and very convenient. It's not expensive. So you finish with that. Okay, so let's move. If you implant a penile prosthesis, surgery is the same as a regular surgery. The only thing is that when you inflate the prosthesis at the end of the procedure, you see that is a deviation of the penis. So you have a few things to do. The first thing and the most popular is do what we call the manual modeling. Manual modeling is that you break everything with the hands. You inflate the prosthesis. When it's hard, you break with the hands and you put the penis straight, okay? And then you tell the patients to do that at home every day. When you start to use the prosthesis, they bend, and in 3 months it's completely straight, okay? Other times, after you do that, there's still some curvature, then you can make application, or you can make an incision, you put a graft, like a normal Peyronie's disease surgery, okay? This will be the modeling. You put that, you break that, and you keep that for 30 seconds or a couple of minutes, and many times that is enough, okay? So this is the end of Peyronie's disease. Any questions? And let's move to the other. Yes?
Okay. For the Apex, I know it's not allowed anymore, I think in Europe, I don't know. In France, we don't have it anymore. So for stable disease, it's surgery first line now?
Yeah, well, I mean, you can use other things. You can use interferon or verapamil. I think efficacy is not so much, but there are in many countries, was removed from the market, but not because of the lack of efficacy.
It's economic.
It was because of the company reasons. They were not selling too much. I don't know in the UK, Sachs, you know what happened with the Ceapex or Ceaflex in UK?
Yeah, I think it's expense, and they felt that they would focus on other plastic areas. So I think it's the expense of the drug that was the problem.
Yeah, well, it was very expensive. You know that every dose of Ceapex, you need probably 8 doses for a treatment, was, at least in Spain, was at least 800 euros. So if you multiply 8 by 8, it's 6,400 euros just the medication. You need a doctor, and then probably the improvement will be less than 20% improvement of the curvature. So the efficacy was low, but still, was a little invasive treatment, and maybe you can use that in some patients if they will. Yeah.
In the treatment of the acute phase, there was in the recommendation, we can offer tadalafil, but what is the mechanism of pain killing with tadalafil?
I didn't get you. Say again, please.
In the treatment of the acute phase of Peyronie's disease, we can offer tadalafil in the recommendation.
Yeah.
What is the mechanism of pain killing with the tadalafil?
Well, I mean, the tadalafil is not doing anything in the Peyronie's disease. The only thing is that improving the erection, and probably if you use a penile stretcher, so you stretch from outside the penis and you stretch from inside, producing harder erections, maybe it's good. But there is no evidence, scientific evidence that this is working. There's evidence that the stretching from outside is working. There's no evidence that tadalafil is having there's some publications, but it's not robust evidence that it's working. But still, I particularly personally use that in the patient. So I have a patient with a Peyronie's disease in the active phase, and I recommend to use a penile stretcher and tadalafil every day. This is what I do, but it's not based on the in the guidelines. It's just my way. I have 10 minutes for priapism. Priapism is not so common, but it's important for you to know how to manage that, okay? Priapism is a disease. Can I have my presentation, my third one? This is me.
Excuse me. Can I have a question?
Yep.
Well, we have paused. The question is, while we use application techniques, patients sometimes complain for pain or something like this because they can feel sutures. How do you manage this problem?
Well, I mean, normally what you use is absorbable sutures. I don't like to use proline or sutures that are not going because they're not absorbed because they feel that. You know, the skin, the penis doesn't have any kind of fat underneath. So everything is very, very palpable. So if you're doing a surgery for Peyronie's disease, it's better to use, not monofilament. I'm sorry, I didn't say that very well. I normally use something that is not monofilament, because monofilament is what you feel, okay, unless it's absorbable. Normally I use some kind of silk. It's not silk, but it's, I can't remember the name now. This is the, I can't remember the name. But it's something that is non-absorbable, but it's not monofilament, so you don't feel that very much. And always I try to cover that with something. If I do application, still I put some Tachosil on top to cover that and to not to feel the sutures. But that is a problem. Many times they complain about that. So they complain because they feel the knot and they feel the suture. Don't use the monofilament, don't use proline because they will complain and you will have to go and remove that. You can use also Vicryl, but if I have had patients, particularly if it's a congenital curvature, young patients with strong erections, that this breaks, okay? So and it becomes curved again. So don't use that in congenital penile curvature, maybe in Peyronie's disease with not so strong erections. And I try to I always tell my patients, avoid that sexual position that the patient is in lying down and the couple is on top, because it's a very dangerous position, particularly after surgery, because it's more chances of having a problem, okay, having pain. Priapism. Also, two types of priapism. The most common is the veno-occlusive mechanism priapism, or the ischemic priapism, also called ischemic priapism. There is no circulation of blood in the penis. The penis is in erection. Probably there is the mechanism of contraction of the smooth muscle is paralyzed. So there's an erection, and the erection is not going. Even though there is no sexual stimulation, the patient is in erection, okay? Sometimes it's due to hematologic abnormalities. Other times it's for reasons that we don't know, idiopathic, we call. Sometimes it's because the patient has injected medication that produces this relaxation that is paralyzed. whatever. This is one type. It's a medical emergency. So the patient is coming to the emergency room, and you need to treat the patient, treat the patient in that moment, right away. There's another kind of priapism. It's called high flow or arterial priapism. Is due to a trauma in the penis, and the trauma produces in the penis or in the perineum, and the trauma produces a laceration of the cavernosal artery, and the artery is bleeding in the lacunar space of this cavernosal tissue. Okay, when there's bleeding inside the cavernosal, the lacunar space is making this shear stress effect in the endothelium that releases nitric oxide. And the release of nitric oxide produces an erection in the patient. Okay, so has a trauma in the penis, there is this fistula, there's bleeding inside the lacunar space, and there's the production of an erection. The erection is only due to nitric oxide, the endothelial nitric oxide. And why is this important? Because it's not a rigid erection. The penis is soft, is elastic, is not completely rigid, is not painful. In the other case, it's painful. And if they have sexual stimulation, the erection is better. So it's not a medical emergency. You can be years with that without any problem. The only thing is the patient comes and says, "Doctor, I have a problem. I fell in my crotch, whatever, and then I had an erection and it's not going out. Why is this? Oh, this is whatever." Okay? So these are the two things. Much more frequent, the veno-occlusive or the ischemic priapism. And the other one is the cavernosal, the arteriolacunar fistula, okay? Lacunar, it establishes a state of high flow in the penis. It's a different thing. High flow, low flow. This one is an emergency. The other, you can have a delayed treatment. Differences. One, in the ischemic, the erection is rigid. There is penile pain because there is ischemia in the penis. The cavernosal tissue is ischemic after some time. If ischemic, and then it's painful, and if you put a needle in the penis and take some blood, the blood has a low pH, acidosis, low PO2, hypoxia, and all that. So abnormal blood gases. And sometimes you have blood abnormalities and hematologic malignancies, sometimes injections of intracavernosal drugs. Okay, so the other one has perineal trauma. Perineal trauma normally present, okay? This is the difference. This is normal erection. When you increase the cavernosal pressure, the PO2 also increases, so it's arterial blood inside the penis. Even though there is high pressure, there's arterial blood. In priapism, there's low pH, a low arterial blood. After 4 hours, is almost incompatible with the survival of the cavernosal tissue. 24 hours after is completely dead, okay? There's no way that if a patient says, "Okay, doctor, I've been 3 days with this erection, it's painful. At the beginning it was very painful, now it's less, but it's completely rigid." There's nothing to do to recover normal erection, okay? These are the reasons for priapism. Okay? Okay, so this is diagnosis. Diagnosis is an ischemic. History, blood, penile blood gas analysis, and Doppler, okay, in both things. In the ischemic, painful, rigid erection. Blood, dark, hypercapnia, acidosis, and hypoxia. Doppler ultrasound, there is no flow, okay? In the other, the contrary, you see there is no perineal trauma, there is no pain, erection is fluctuating, it's not completely rigid, there is normal blood gases inside the corpus cavernosum, and if you do a penile Doppler, you see the fistula. Sometimes you see the fistula, and even though if you compress the fistula, you can close the fistula, okay? And maybe that could be the treatment for this case, okay? If you see very well the fistula and you press and you collapse the fistula and you keep that for a few minutes, and sometimes it's like you have arterial bleeding, and you press and it goes, okay? So that is maybe a treatment, okay? Recommendations. What we do if we have a ischemic pre-appeasement. First thing you do, you put you can do a MRI of the penis, of course, to make a decision. But in general, let's say you decide that you're going to treat pharmacologically this case, okay? You put you block with anesthetic the penis, and you place a large needle in the penis. If you place a large needle and then you flush the penis and you try to remove all the clots, okay? Because there are clots inside the penis and the blood is very thick, and then you remove that, you wash with saline, wash, remove, and then when it's a little bit soft, then you start to inject what? You inject an alpha agonist agent. You can use a few of them. Normally, in every hospital, you have phenylephrine, which is the most efficacious because it's alpha-1, pure alpha-1 adrenergic agent. That is what you want to contract the smooth muscle. You want to contract the smooth muscle, okay? Instead of relaxed, you want to contract. This is the drugs that you can use: ethylephrine, phenylephrine, methylene blue, adrenaline, terbutaline. Of course, if you use adrenaline, you need to check up upon the cardiac blood pressure, cardiac events and all that, because they have not only alpha but also beta effects, okay? Well, that's why phenylephrine, what is available in every hospital, you can use, okay? You take an ampoule, I mean, it's quite easy. You take an ampoule, 200 micrograms, and you dilute in 10 mLs of saline, and then you inject 1 or 2 cc's every 15 minutes, every 10, 15 minutes, to see how is it responding, okay? And you be like that for 1 hour. Did it produce another erection? Then you remove, you take blood, and then you inject a little bit more, and you inject a little bit more. And after 1 hour, if it's filled and completely rigid, then you decide this is not going to respond. This cavernosal tissue is not responding to the, the alpha adrenergic, and then you take the patient to the operating room and make what? Make a shunt. Instead of removing the blood from with a needle, you want to remove the blood in a communication between the corpus cavernosum and the spongiosum, okay? You make a window, some kind of window in the spongiosum and the cavernosum. If you see one thing you can do, if you have a patient that the aspiration and injection failed, then depends on the time, okay? If it's less than 24 hours, you go and make the shunts, okay? You go with the patient to the operating room. If it's more than between 24 and 48 hours, you make an MRI. If it's more than 48 hours, you don't make an MRI and you don't do anything. You just tell the patient, okay, we cannot do anything. The only thing we can do is to implant a penile prosthesis right now or tomorrow or the day after tomorrow, soon. But there's no way that any kind of medication can recover that, okay? If you do the MRI, you can have a necrosis. Then if you have necrosis, you go in the penile prosthesis way. If you don't have necrosis, you go in the shunts, okay? Shunts, in my experience, the majority of the times are not working, but still there's a chance that you can give to the patient, okay? There's some ways to do that. You can use a true-cut needle, a biopsy needle, to make small communications between the tip of the corpus cavernosum and the glands, or you can use a scalpel, T-thin, or you can, which is the most commonly used technique, is you make an incision in the middle of the glands and you remove a piece of the tip of the corpus cavernosum and then you close the glands, okay? This is called the Al-Ghorab shunt. It was an Egyptian doctor that did this technique, okay? What is this working because the blood, instead of accumulating in the corpus cavernosum, is going to the corpus spongiosum, and it's like you are removing that. What is the problem of this? If it's working, you will have an erectile dysfunction because you won't have a rigid erection anymore. Okay, so that's why this type of shunts, you need to think about that. This is another maneuver. You can do proximal shunts also, make this window between the corpus cavernosum and the spongiosum in the crural part of it, in the back part, or even using the saphenous vein in the corpus cavernosum, whatever. Priapism, penile prosthesis and priapism. Why early? Because you don't have fibrosis, then the insertion is easy. You keep the length of the penis instead of producing a fibrosis and a retraction of the penis. So you tell the patient, you are not going to have a good erections anymore, so we need to implant a penile prosthesis, and it's better to do it now than later. Now you keep the length of the penis, and the insertion is easy because there's no fibrosis. If you do it late, there's a problem, okay? More difficult, penis is shorter, and the patient is not going to be so happy. So this is the end of my, participation today. It's also my last participation in Europe. It's my 5th year. Well, last year there was no Europe last year, but this is my last one. And I'm very happy to be here with you, and I hope you enjoy this experience that I think is amazing. It's one of the best that you can have as residents, and thank you very much for your attention.
Noch eine Stunde so. Na, komm mal.